Hey friends, it's good to be back. The Flint Community Webinar, your community resource. We've got so much great expertise today. I'm so excited to bring a couple of people to talk to you about lymphoma and have a great conversation about cancer care. My favorite part about this conversation is it utilizes our whole ecosystem in Flint. So we've got the Hurley Genesis Cancer Institute that we're going to talk about. We've brought a Flint training alum back to talk to you a little bit about what we need to understand about lymphoma. Great expertise today. I'm going to get started and have Dr. Jonathan Weiss, who is a CHM alum and a Flintstone, to talk to us a little bit about what we need to be thinking about when we talk about lymphoma. And don't let the Go Blue fool you. He's a green and white grad through and through. But we have a lot of love for the maize and blue next door.
I love that.
Yes. Jonathan, tell us a little bit about yourself, your background, and a little bit about lymphoma that you want to talk to us about today.
Yeah, so I will be a little bit about my background is I was born and raised in Flint. I went to Carmen Ainsworth High School, graduated in 2010, and then went to U of M for undergrad. Then went to Michigan State for med school. So I've been in both major state schools here. And then I did a public health certificate program during my third and fourth year in Flint as a med student. And then I did my residency and fellowship here back in Ann Arbor. So I've been in Michigan my entire life.
That is fantastic. And
Yep.
just a shout out to all of the institutions that trained you. How about that?
Thank you. That sounds great. And today I'll be going over a little bit about lymphoma. I'll be talking about the general basics, what it is, most importantly. It can be a very confusing diagnosis for a lot of people, and how we diagnose it, what the treatment might look like, and then kind of what questions you should be asking your doctor if you ever get a diagnosis of lymphoma. And so that's the majority of what my talk will be today. It'll be pretty basic, but I'm happy to take any questions that you might have.
That sounds amazing. Thank you. All right. Do you have slides we need to prepare?
Yep, I
All right.
have slides here. Let's see if I can get that.
Perfect.
Okay. Can everyone see those okay?
Yes, we can.
Okay. All right. So yeah, the title of my talk is Understanding Lymphoma. And so a little bit about me, I just went over this, but again, I was born and raised in Flint. I majored in neuroscience at the University of Michigan here in Ann Arbor, which is where I currently work. And then I did med school at Michigan State University College of Human Medicine. I was in the public health certificate program there in Flint, and then went over back to Ann Arbor to do my residency and fellowship. So currently, my title is a clinical assistant professor here at U of M with a focus on non-Hodgkin's and Hodgkin's lymphoma. And currently, I have multiple clinical trials for patients with lymphoma in a multitude of different types of lymphoma, which we'll talk a little bit about the differences between these today. But that's what I do is I do some research, helping patients with lymphoma find new and upcoming therapies. And then I also spend a lot of my time seeing patients in the clinic. So by the end of this discussion, I hope that everyone has an idea of what lymphoma is, how our lymph system works, what are some of the common symptoms that patients have when they present with lymphoma, how we diagnose and stage lymphoma, treatment options and goals. I'll talk a little bit about my research as well, and then questions. And I want to emphasize that feel free to ask questions at any point. If there's something that doesn't make sense or that you want clarification on, I'd be happy to stop and answer any questions that anyone has. So lymphoma is a cancer, okay? And it's a cancer of lymphocytes. So I always tell my patients that we all have B cells and T cells and natural killer cells in our bodies, and they're part of your immune system. And they're more specifically, they're white blood cells that help fight infections, and that's why we have them. And what can happen is you can get a cancer of those lymphocytes, and that's essentially what lymphoma is. And it's where these cells start dividing too much. And so it starts in your lymphocytes, but it can really go anywhere in the body. And it can go to your lymph nodes, but it can also go outside of the lymph system, and it can go to the lungs, to the liver, really anywhere in the body. But even though it's in those other organs, it's still considered lymphoma. It's not a cancer of those other organs. It's still lymphoma. And the problem is due to the B cells, the T cells, or the natural killer cells. So what is a cancer? So cancer is what happens when cells grow uncontrollably, when they should not be growing, and they do not die when they should. And so you can get a mass that builds up from these cells that are dividing too much, and ultimately they can spread in different areas and interfere with our normal body function. So normally cells grow in an orderly and organized method with controlled division. But with cancer and with lymphoma, these cells grow too much and they divide too much. So our lymph system is all throughout our body. We have tonsils, lymph nodes, lymph vessels that connect the different lymph nodes. Your spleen is basically a big part of your immune system. It's a big lymph node essentially. And then your bone marrow is where your white blood cells are made. And so these are all part of the lymph system that we all have. And lymph nodes, in particular, are small little filters throughout the body. They're bean-shaped structures that we have in our neck, in our armpits, in our abdomen, in our chest, and they help fight infections. And they have cells that help essentially uh, react to any invader that comes into the body or any infection. And they have B cells and T cells, and they're important for helping get rid of any infections. And lymph nodes tend to swell when there's either an infection or if there's inflammation in the body. And that's usually the cause for a lymph node swelling is some infection or some inflammation that's going on. And rarely the lymph node can swell from lymphoma. So I don't want you to think if your lymph node's ever swelling that that's a sure sign that you have lymphoma. In fact, the more likely cause is some sort of infection or inflammation. So in lymphoma, you have a normal lymphocyte that becomes abnormal, usually due to a specific genetic change in that particular B cell or T cell. It then multiplies too much, and you get collections of these B cells or these T cells, and those can collect in your lymph nodes or really any organ in the body. And subsequently, a lot of times your immune system is not working properly when you have these abnormal B cells and T cells. And when that happens, you're subject to specific infections or complications. So if I want you to take away one thing today, it's understanding that lymphoma is not just one disease. It's a heterogeneous disease with many different subtypes. I often say there's hundreds of different types of lymphoma when you really think about the differences between each different type of lymphoma. And so it's a broad category, it's a big umbrella of multiple different diseases. And so if we first think about how we break up lymphoma, I usually start with, okay, is this what's called a Hodgkin's lymphoma or a non-Hodgkin's lymphoma? And we'll talk a little bit about the differences between these. Within non-Hodgkin's lymphoma, there's hundreds of different types of non-Hodgkin's lymphomas. And we usually think about whether or not they come from a B cell or from a T cell. Okay. And then within B cell lymphomas, B cell non-Hodgkin's lymphoma, there's aggressive and indolent types of lymphomas as well. And so we'll talk a little bit about the differences between these types of lymphomas. So classical Hodgkin's lymphoma or Hodgkin's lymphoma, this is often the lymphoma or the cancer that young patients tend to get. So patients in their late teens or 20s, but really it can occur at any age. It starts in the B cells, and there's a very characteristic pathologic finding that we see with classical Hodgkin's lymphoma, and it's called a Reed-Sternberg cell, and you'll see it shown there in the image, but it often looks like owl eyes is kind of what is it's described as. But this is a very common pathologic finding. This Hodgkin's lymphoma tends to occur again in younger patients, and it's curable. So we can treat this and get rid of it and make it go away completely in patients where it's diagnosed. And we have very, very good success rates, especially with newer and modern therapies. So this is one subtype of lymphoma. It's not the most common subtype of lymphoma, but it is certainly a curable lymphoma, and that's generally our goal. So moving on now to non-Hodgkin's lymphoma, again, very broad category here. We often think about, does it come from a B cell or a T cell? So you might hear the term B cell non-Hodgkin's lymphoma or T cell non-Hodgkin's lymphoma, and rarely what's called a natural killer cell lymphoma or NK cell lymphoma. And non-Hodgkin's lymphoma can be aggressive and need treatment right when it's diagnosed, or it can be what we call indolent or non-aggressive. And so a lot of times when I'm seeing a patient, I'm trying to determine whether or not, okay, do they have a B cell or T cell non-Hodgkin's lymphoma? Is this aggressive or indolent? And then, of course, how should we go about managing it? So non-Hodgkin's lymphoma can be indolent or slow growing. Some patients may not have symptoms for a long time. Generally, these are diagnosed on accident or incidentally. A patient may get a scan for one reason, and they have a big lymph node on the scan or something that's abnormal in their liver or in their lungs. And so we get a biopsy and it comes back as lymphoma. So sometimes those are caught on accident. Or we see something in routine blood work. Aggressive lymphomas, on the other hand, most patients present with symptoms. And symptoms we'll get into in a little bit, but they can appear pretty quickly. And aggressive lymphomas tend to progress and need treatment more urgently. So the common symptoms for lymphoma are non-specific symptoms, meaning we tend to see the same symptoms that a patient might have if they have a viral infection or any type of infection or inflammation in the body can sometimes mimic what we see with lymphoma. But the more common symptoms are swollen or big lymph nodes, fever, night sweats, unexplained weight loss, fatigue, and I usually say fatigue is to the point where it's hard to get out of bed in the morning because you're so tired, or go to work sounds like an impossible task because you're so tired. Itching is a possibility, cough or shortness of breath if there's pulmonary involvement. And then sometimes the spleen can get bigger as well, which can cause the belly to swell and get bigger and lead to difficulty with eating. You might hear doctors use the term B symptoms. And so B symptoms is referring to kind of this triad of fever, drenching night sweats, and unexplained weight loss. And we often say those are B symptoms. When we see drenching night sweats, usually that's to the point where you can wring out the sheets in the morning, or you have to change your clothes in the middle of the night because you're sweating so much. That's how much we see with the drenching night sweats. And then unexplained weight loss can be for a few different reasons, the inflammation in the body, the big spleen, and some of the stress that comes with getting this diagnosis. But patients will sometimes lose anywhere from 10, 15, 20% of their body weight from this. So when should someone seek medical care? So I think it's reasonable to reach out to your healthcare provider if you have a lump that does not go away and that's getting bigger. Chances are it's not lymphoma. Chances are it's a reaction to some inflammation or an infection, but it's worth getting checked out. And usually what we'll do is a biopsy. If you have unexplained fevers or night sweats, it's worth getting those checked out as well. And then weight loss is always something that should be evaluated. And now a lot of patients are on these GLP-1s and these different diabetic medications. So I spend a lot of time teasing out if this weight loss is related to medications or is it from the lymphoma. So that's just kind of in the modern era here. Severe fatigue, again, to the point where it's hard to get out of bed, or any of these symptoms that just are not going away. So there's no clear cause for what brings about lymphoma. It's not like smoking and lung cancer. There doesn't tend to be one known risk factor that certainly causes lymphoma, but there's multiple things that tend to have a higher risk for lymphoma. One of those is as you get older, you're more likely to develop a lymphoma. Weakened immune system as well. So if you're on medications that suppress the immune system, so patients that have an organ transplant are at higher risk of developing a lymphoma, and we have a term for that called a post-transplant lymphoproliferative disorder. That is something we tend to see. Certain infections can increase your risk for lymphoma. So, of course, HIV or Epstein-Barr virus, which is what causes mono, those can increase your risk for lymphomas. Um, Autoimmune conditions, there tends to be a correlation between patients with autoimmune issues, lupus, rheumatoid arthritis, and developing lymphomas as well. There tends to be a propensity for these lymphomas to run in the family, even though there's not a specific gene we test for, like in, let's say, breast cancer, which has a very clear gene that increases your risk for breast cancer. We don't have a similar thing in lymphoma, but they too do tend to run in the family. If you've had prior chemotherapy or radiation, you're at higher risk. And then certain environmental exposures, like some of the weed killers and Roundup and things like that, have been associated with lymphoma. But there's no one thing that if you have that exposure, you're certainly going to develop a lymphoma. I think it's really a weak immune system can lead to lymphoma. And so or an abnormal immune system, like in what we see with some of the autoimmune issues. Lymphoma is not contagious, so you do not have to worry about getting lymphoma from hugging someone, sharing food, or being near someone that has lymphoma. So how do we diagnose it? So there's a few different tests, and I'll go through some of them. Certainly, a physical exam is important. That's where a doctor might feel for the size of your lymph nodes, your spleen, whether or not that's big or not. Those are important things that I always examine on my patients to see if there's any abnormalities there. Blood tests are important. So when you have lymphoma, you can have some of that lymphoma take over the bone marrow, which is the factory for making your red blood cells, your white blood cells, and platelets. And when that happens, we can see anemia develop. We can see a low platelet count. We can see a drop in the white count as well. And so those are things we kind of trend on blood work. Imaging studies are important. So we tend to use what's called a nuclear medicine PET scan to stage and evaluate lymphoma, which shows us metabolic activity throughout the body. But we also might use an ultrasound or CT scans periodically as well. Lymph node biopsy tends to be the most important test for diagnosing lymphoma. Most lymphomas need to have a tissue sample of a lymph node to tell us exactly what we're dealing with. Sometimes we will go into the bone marrow, which is again the factory that makes all of our blood cells to see if there's any abnormalities there. And then special lab tests, this is usually going to be genetic testing on the specific B cells and T cells, and then some other more genetic based testing. So a biopsy is where we remove a piece of tissue from the body. We look at it under a microscope and we run different tests on it to see exactly it'll tell us exactly the subtype of lymphoma that we're dealing with. So a pathologist is able to tell me, okay, this comes from either a B cell or a T cell. And based on the certain characteristics, this is a specific type of lymphoma, whether it's an indolent or aggressive lymphoma or some of the more rare subtypes of lymphoma. And they do that by looking at specific cell markers, genetic changes, or lymphoma specific markers. In terms of imaging tests, so again, CAT scans give us an idea of how big the lymph nodes are, but what tends to be the most useful test that we order are PET scans. And PET scans give us an idea of how metabolically active a certain area is in the body. So whether or not it's if an area like a lymphoma is very metabolically active, it'll take up some of the sugar that we use on a PET scan, and it'll show up very bright on a PET scan. The problem is PET scans can be very sensitive tests, and just because something's taking up sugar certainly does not mean that it's lymphoma. Any inflammation in the body can cause a PET scan to light up and be brighter. And so sometimes we have to do some additional biopsies to figure out exactly what we're dealing with and seeing on the PET scan. But it can be a very useful tool to see how patients are responding to treatment. MRI, we'll do MRI brain sometimes if there's concern that the lymphoma has gone to the central nervous system, but that isn't a routine test that we do. So staging lymphoma. Um, this is something we do with most lymphomas is we do stage them, and this is often a question that our patients have. But staging in lymphoma is very different than in other cancers in that lymphoma is unique in that we can cure some stage 4 lymphomas even when they've gone to multiple areas. So even if it's stage 4 above and below the diaphragm, we can still cure some of these lymphomas, which is certainly different than other cancers. But the way we formally stage it is actually called the Ann Arbor staging criteria, which is used all over the world. And so if it's stage 1, it means it's only in one area in the body. If it's stage 2, you have more than one area, but they're on the same side of the diaphragm. Stage 3 would be above and below the diaphragm. And then stage 4 is in multiple locations, including the lymph nodes, but also outside the lymph nodes, so in different organs as well. Okay, so I want to emphasize that point again. So staging in lymphoma is unique in that stage 4 lymphoma can sometimes be curable, and stage 4 lymphoma does not always need to be treated. So it's because each different lymphoma is so particular in how we manage it. There's a wide range of possibilities with a stage 4 lymphoma, and that's not particularly as important as some of the other pathologic characteristics that we look at. So that makes lymphoma unique relative to other cancers. So how do we treat lymphomas? So it depends on multiple different factors, including what's the subtype, what's the cell of origin, does it come from a B cell or a T cell? Staging does play a role into how we think about things. Is the patient symptomatic? Are they having those B symptoms I mentioned? Are they have other lab abnormalities like anemia or thrombocytopenia, meaning low platelets? What is the age and the functional status of the patient? And then what are the patient preferences as well? Do they want treatment or do they prefer close monitoring? These are all things that we take into account. But some of the options that we may consider include watchful waiting. A lot of the indolent, non-aggressive lymphomas that I see, I tend to just watch. If it's not causing any problems, not causing any symptoms, patients are feeling okay, then we will just watch it. And that usually means come to the office every 3 to 6 months, get blood work and do a physical exam, and then just kind of go from there. Chemotherapy is also a mechanism that we use to treat some of these lymphomas. There's a wide range in the types of chemotherapies that we use. We have non-intensive chemotherapies and then more intensive chemotherapies that we use for some of the more aggressive lymphomas. So it kind of depends, but chemotherapy is an option for patients. Uh, a newer type of therapy is what's called immunotherapy, And this uses the body's T cells, which are infection fighting cells, to basically attack the B cells. So you train the body's immune system to recognize the lymphoma cells as if they're a foreign entity. And ultimately, these immunotherapies have been very successful in helping us improve outcomes in patients with lymphoma. Radiation therapy has a role as well. So if patients have one area on the body that's causing discomfort or pain, then sometimes we'll use radiation techniques to target the lymphoma. Targeted therapies, these are therapies that are usually either pills or IV treatments that target specific pathways in the B cell receptor. And these have been very successful recently. In the last 10 years, we've had over 10 approvals for some of our more aggressive lymphomas, 10 FDA approvals in new treatments. In the 20 years prior to that, we had one. So just to give you an idea, there's been a lot of exciting things in lymphoma and a lot of new things happening. But just to round it out, we have stem cell transplants. That's something I'll talk about briefly that we sometimes use. And then CAR T cell therapy is now a standard treatment for patients with lymphoma. So again, watchful waiting is something that I'll do for indolent or non-aggressive lymphomas. This will generally be just coming to the office every few months, looking to see if there's new symptoms that are developing and whether or not we have to start treatment for these lymphomas. Chemotherapy, this is usually an IV, but sometimes we do have oral chemotherapies that we can use. And this is a good method for shrinking down lymphomas. Lymphomas are very sensitive to our chemotherapies. Some of the common side effects that we see from chemotherapy, which you might be familiar with, can sometimes cause fatigue, nausea. We've got pretty good nausea medications, but that can sometimes be a problem. And then hair loss with some of our more intensive regimens. We have to monitor blood counts sometimes because it can suppress your bone marrow. And then I would say the biggest problem that we come across and the thing that makes people end up in the hospital sometime is infection risk. So patients on chemotherapy are at higher risk for infections, and we sometimes need to have them on antibiotics to prevent that from happening. I would say overall, I know chemotherapy has a connotation to it, but a lot of our patients tolerate these pretty well. I have patients that go to work right through their treatments and end up doing pretty well. I mentioned immunotherapies. These are therapies that help use your own immune system to target the cancer. Bispecific antibodies are an exciting new medicine that have been approved recently for different lymphomas and work really well in activating those T cells. And then CAR T cell therapy is where we actually remove patients' T cells or infection fighting cells. We re engineer them to recognize the cancer and then give them back to the patient. And those have been very successful as well. And then we have different targeted therapies and antibodies that we use also. Radiation therapy is a good technique for actually targeting specific areas in the body that are acting or causing discomfort. It'll target one area, and lymphoma is very sensitive to radiation as well. Stem cell transplant, this is something we tend to do if patients have either a more aggressive lymphoma or if they are refractory to some prior treatments. So there's two types of stem cell transplant. There's what's called an autologous stem cell transplant, and that's where we give high doses of chemotherapy and then rescue patients' bone marrow afterwards with their own bone marrow cells that they gave before they received the chemotherapy. And then there's what's called an allogeneic stem cell transplant, and that's where we give them a donor's new bone marrow system. And so both have their indications. They're pretty intensive therapies, so obviously that's only something we do when we have to. And then I mentioned the CAR T cell therapy, which is a way for us to use the T cells to attack specific cells in the body. So, as you can imagine, treatment can be a lot for patients. We use a lot of anti-nausea medications, medications to help prevent infections. That tends to be one of the bigger problems. Sometimes patients need blood transfusions, which requires them coming in and getting additional labs. We like to provide nutrition support. I always tell patients generally they can eat whatever they need to. I want them to maintain their weight during the chemotherapy. I like for patients to continue their routine, their exercise routines. It's not a time to start a new exercise routine, but certainly if walking or running or low intensity weight exercises are important for patients, I like them to continue those. Emotional support is important. And then for our young patients, fertility counseling is also something we recommend prior to starting any of the chemotherapy. So life during treatment can be very difficult for a lot of our patients. You can imagine a lot of our patients, lymphoma affects a wide range of individuals from young patients in their late teens to and even younger sometimes, all the way up into till end of life. So sometimes patients have kids, they have jobs, they have difficulty with transportation and childcare. And so having a good social work support is very important for our patients. We need to make sure they're able to get food, childcare, if their works are can help accommodate, and then some of the emotional stress and dealing with that, as well as the finances, can be very important. So it can be for some of the treatments that we give, it can be very life altering until they get through it. Prognosis is variable depending on the type of lymphoma, what the stage is, how old is the patient, how big of an impact is the lymphoma having on the patient's life. So it's a wide range in terms of what the prognosis is. A lot of the indolent, non-aggressive lymphomas have a great prognosis, and patients may not even need treatment. And then some of the more aggressive lymphomas, we try to cure them, but if we're unsuccessful, it can be harder to get it under control in the later lines of treatment. We use some terms, and I just wanted to clarify what these terms are, because it can be confusing when doctors say certain things. Sometimes you might hear doctors use the term remission, and I think if your doctor ever says that, it's important to clarify exactly what they mean, because every doctor, I think, uses different terminology when it comes to what remission means. But for me, if I tell a patient they're in remission, I generally mean that we don't see evidence of the lymphoma on their scans anymore or in their blood work. That doesn't necessarily mean they're cured forever, but we don't see evidence of the disease on the nuclear medicine PET scan. I usually would then say it's a complete radiographic remission. Relapse is a term we use when the lymphoma comes back after having been in a remission. And then the term cure I can use if a patient was treated for a lymphoma that is curable and they're usually about 5 years out of treatment. Sometimes I will use the term cure because the risk of the lymphoma coming back at that point is quite low. So, some myths and facts about lymphoma. One of the myths would be all lymphoma is the same. There are many, many different subtypes of lymphoma, and they're all managed quite differently. A myth is stage four is always hopeless. I would say the fact is that some stage four disease is curable. Some lymphoma stage four disease doesn't even need to be treated. So staging is not always super important there. Um, the next myth is that lymphoma is contagious. Lymphoma is, in fact, not contagious. A swollen lymph node always means cancer. That is not true. Most of the time, a swollen lymph node is due to infection or inflammation. That's a much more common cause of a swollen lymph node. Again, we all have lymph nodes all throughout our body, and most of the time, they might get bigger or smaller if you have some infection or inflammation or got a vaccine recently, and that's totally normal and totally okay. Lymphoma happens when is a concern when the lymph node is getting bigger, 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 and not slowing down. So if you ever get a diagnosis of lymphoma, what I would recommend asking your doctor is certainly what type of lymphoma do I have? Is this an indolent or slow-growing lymphoma, or is it a more aggressive, fast-growing lymphoma that needs treatment? What stage is it? Do I need treatment now, or is this something we can watch? What are my treatment options? What side effects should I expect with the treatment? What is the goal of treatment? This is really important in lymphoma. Sometimes our goal is to cure the lymphoma and make it go away and never come back. Sometimes our goal is to just shrink things down, make patients feel better, improve things like anemia or low platelets. But the goal of treatment is very different depending on the circumstance. Should I get a second opinion? Should be a question to your doctor. I generally recommend my patients, if they're interested, get a second opinion. Sometimes we're dealing with rare and unusual types of lymphoma, and it's always good to have a second set of eyes on things. And then, are there clinical trials I should consider? For some of the more aggressive lymphomas that we have a tough time curing, I think it's always a reasonable idea to consider a clinical trial if available. So some of the takeaways here, lymphoma is a cancer of the lymphocytes, which is a type of white blood cell that's either a B cell, T cell, or natural killer cell. It often involves lymph nodes, but can certainly occur elsewhere. There are many types of lymphoma. We usually get a biopsy to diagnose lymphoma. Treatment depends on the type of lymphoma, where it is, patient factors, a lot of different things. Many lymphomas are treatable, some are curable, and having a good support system and family and community is really important when you have a diagnosis of lymphoma. I want to briefly talk about a little bit of the research I do and some of the lymphomas that I treat at the University of Michigan, and then I'll open it up here for questions. But one of the lymphomas I treat is what's called a cutaneous T cell lymphoma, also known as CTCL. And this is a rare type of T cell lymphoma that tends to go to the skin. The most common variants are what's called mycoses fungoides. But there's many different types of even cutaneous T cell lymphomas, and that's all the types that are listed there. So you can see even within this rare type of lymphoma, there's many different subtypes of that rare lymphoma. And what's unique about CTCL is that if the higher stage you have, the worse the prognosis is. And so, relative to some of the other lymphomas that I mentioned, patients with advanced stage cutaneous T cell lymphoma tend to have poor outcomes. However, those with stage one disease tend to live as long as an age matched control. So, patients with limited stage CTCL tend to do fantastic. However, those with advanced stage disease do quite poorly. And with extensive stage disease, we really have no curative options. There's some FDA approved therapies in advanced stage cutaneous T cell lymphoma. But part of what I get to do with my appointment here is actually put together in clinical trials and help arrange and work and develop clinical trials for patients with some of these rare lymphomas. And one of those clinical trials is what's called pembrolizumab and mogamulizumab that we're using in advanced stage cutaneous T cell lymphoma. Pembrolizumab is used in multiple types of cancers. You may have heard of it. And then mogamulizumab is more of a specific for cutaneous T cell lymphomas. One of the major problems when it comes to cutaneous T cell lymphomas is that patients that live farther away from academic centers or in some of the rural areas have a higher risk of dying from their cutaneous T cell lymphomas than those that live in metropolitan communities or closer to major academic centers. So part of what I've been doing is trying to figure out some of the barriers to patients that come from rural areas in terms of getting onto some of these clinical trials that can be very important for patients. there's many different factors for why patients might have a hard time in getting onto some of these clinical trials. They may be structural factors, meaning they're just farther away from a clinical trial site. Clinical factors, so patients may be too sick to travel and get on a clinical trial. Physician factors, sometimes it's hard for doctors out in the community to offer some of these clinical trials for more rare cancers. And then there's patient factors as well of whether or not they actually would like to enroll in a clinical trial. So part of my what I'm trying to do is improve enrollment on some of these clinical trials for patients from rural areas. Certainly, I'd like to expand that into any community that needs access to some of our clinical trials, and certainly that includes the Flint community as well. Um, but the way I'm doing that is just identifying those barriers, developing education material about why these clinical trials can be important, and then hoping to become a consultant for some of those rural communities and the doctors that work there. Some of the reliable resources for patients with lymphoma are the Leukemia and Lymphoma Society, American Cancer Society, and the Lymphoma Research Foundation. Also, I'd be happy to share my email if anyone has questions. I'd be more than happy to talk with anyone that has specific questions about lymphoma or cancer in general. And so that's all I have, but I'd be happy to take questions. Thank you all for your attention.
That's all you have. That was such wonderful information. That is by no means all you have. That was so wonderful. I appreciate so much. I'm a family doc and still walked away with just like so much of a more thorough understanding of what we need to be thinking about, and what's important. Very, very, very cool.
Thank you.
The one thing I walked away with, quick MSU plug, because I'm supposed to, right? But I walked away with such pride and such respect for the work that you do relative to not everyone has an understanding that there are communities that don't have access to a major tertiary medical center to be able to get their care. And this sense that you have that you need to be thoughtful about not only the people who have access to where you are, maybe in Ann Arbor, but the people who don't, and to study the barriers is the only way we get at that. And that's a lot of the work that we do bringing people on the webinar. Some of that is education, making
Mhm.
sure people understand the conditions that they might not otherwise have access to the expertise to understand.
Yeah.
So shout out to you and the work that you do and
Um,
the thoughtfulness behind that.
well, thank you so much. I appreciate that. And yes, getting patients access to the things that we offer here and that other major academic centers offer is really important. And Michigan State has a rural health foundation, and then of course what you guys do in Flint also is really important. And so just thinking about partnerships and ways to get patients access to these therapies is really important.
Absolutely. We do have a couple of questions for you. There were lots of questions popping up while we were going through things. One of the questions that was sort of early on, you were talking about what happens when people receive cancer treatment and how they can be at higher risk for certain infections. And could you talk a little bit more about why that happens?
Yes. So some of our treatments, particularly chemotherapy, but even some of our immune-based therapies, can cause bone marrow suppression. And so the bone marrow is really important for making healthy white blood cells, which are infection fighting cells. And when we give chemotherapy, it can knock out some of those healthy white blood cells. And sometimes you might hear that doctors use the term neutropenic,
Mhm.
which is where we get rid of the neutrophils, which are super important for fighting bacterial infections. And so doctors' heart rates kind of go up when we see patients are neutropenic and they're coming in with fevers and things along those lines. So our chemotherapies can frequently make patients neutropenic. And when that happens, we have to give certain medications to help prevent infection. So I would say that's the biggest thing is the bone marrow suppression that occurs from our different treatments.
That's super helpful. One of the other questions we had is just this idea, and you talked a little bit about it. I think when people think about cancer, they're like, what can I do to prevent or screen ahead of time or
Yeah.
be really sure. And some of us, there's a little bit of education going around about like genetic tests to understand what your risk might be. Is
Yeah.
there anything people should be considering in that space?
When it comes to lymphoma, not much. Obviously, other cancers like breast cancer and mammography and colon cancer and doing colonoscopies. And if you have a smoking history, doing a CT of your chest, those are all things that your primary care doctor can certainly talk to you about doing. When it comes to lymphoma, there's not specific screening recommendations that we have. And there's no single risk factor that we have to say, you have to stop doing this. So what I usually recommend to my patients is kind of what most I think primary care doctors recommend to their patients, which is um, eat a well-balanced diet, watch out for things that spike your blood sugar, keep your weight under control, watch your blood pressure. Those types of things are going to make you live a long and healthy life. And if you get lymphoma, having those things under control allows us to use our therapies. But besides that, there's nothing else that I would really recommend.
That's super helpful. Any last things you want to make sure people walk away really understanding about lymphoma? You gave us a bunch of really hidden gems and things to be thoughtful about. And I appreciated so much your myth slide, right? The idea of the things you hear that
Yeah.
aren't true. Any last things we should walk away with, or you want to make sure the Flint community is thinking about as we think about lymphoma?
Yeah, yeah. I mean, I think, lymphoma is somewhat common. So there may be someone listening that has a family member impacted or even themselves. And I just want you to know that we can cure some lymphomas even when it's stage 4. And some lymphomas are indolent and non-aggressive and don't even need to be treated. And so if you get the diagnosis of lymphoma or a family member does, just wait to talk with your doctor before making assumptions and before Googling or using ChatGPT, because all those things can make you quite anxious, I think. And a lot of times it might not even be something we need to treat.
Yeah. Two last things. What does indolent mean? Just for
Yeah.
everyone out
Yeah,
there.
yeah, yeah. So indolent means non-aggressive, or a lot of times we use it in the context of lymphomas that are very slow growing and that don't necessarily need to be treated.
Dr. Weiss, we are so happy to have you. And I sent messages to all of our Flint people who were just like, we remember him. He's so amazing.
Oh,
And people are
thanks.
so proud to have you on the webinar. I appreciate so much the research and work you're doing and expect to hear back from us so we can think about, what are the opportunities to make sure Flint is included in that expansion of thinking about barriers to access and barriers to care. There's a bunch of people asking when we can get this presentation back again. This is live on our YouTube channel, and you can watch it again on the YouTube channel. And I think either our wonderful friend Blair can throw in the link, and we'll make sure everyone has access to that. Thank you again, Dr. Weiss, and go green.
Thank you. Thank you. I'll say go white.
All
Okay.
right. Appreciate it.
Yeah.
Kim Van Slyke, I'm so excited. What a wonderful parallel for us to think about all of the disease process of lymphoma and understand how that happens, and then think about our resources in the community and how Hurley's working together with Ascension and thinking about that connection for treatment and resources for people. So love to have you talk about those resources in that ecosystem we have available to patients in Flint.
Yeah, hi, great. Thanks for having me today. Shout out to Dr. Jonathan Weiss. I will say to start with that if it weren't for large hospitals and university research facilities like the University of Michigan, um, we would not be able to offer these services here in Genesee County. It is because of large universities and partnerships with large universities and research communities that national protocols have been developed. And it is the best practice of all cancer institutes to follow those practices. And so we can offer the majority of those right here in Flint. And I will take just this moment to point out so here's our first slide, Genesis Hurley Cancer Institute. I'm not Flint native, but I'm Genesee County native, born in Davison, but raised in Davison. Mott Community College to start with, University of Michigan Flint for 2 degrees. And I'm here at the Cancer Institute and still teaching with the nursing program at the University of Michigan Flint. So welcome, and come on and stop by and see us sometime. We are located at 302 Kensington Avenue, Flint, Michigan, right on the north side of Mott Community College campus. We are on the campus where St. Joe's Hospital used to be. If you've been in Genesee County for very long, you know that St. Joe's was one of the hospitals that was combined to create Genesis Regional Medical Center. We here at Genesis Hurley Cancer Institute were established as a nonprofit in 2001, officially opening our doors on February 14th. Love that. 2002. Originally, we were a joint venture between Genesis Regional Medical Center and Hurley Medical Centers. That moved on to be Ascension, but now we are actually part of the Henry Ford Health System. So we are a joint venture between Henry Ford and Hurley Medical Center. We provide compassionate cancer care right here in your backyard, right here where you need us. We are just steps away from everybody in Genesee County, and we service Genesee County, north of Genesee County, east and west of Genesee County. We lose a lot of traffic south of Genesee County because they head down to U of M, but that's okay, we'll forgive them. Here at GHCI, we have medical oncology services. Our partner is Cancer and Hematology Centers of Michigan. They're actually a private practice. We have 6 physicians up there, 3 fellows and multiple nurse practitioners and physician assistants seeing patients. You'll understand why we need that many in just a moment. We offer radiation oncology services here. We have a multitude of social and financial support services available to our patients. We do have research trials, both through the hematology, or Cancer and Hematology Centers of Michigan, and also cancer prevention trials through our own research department. We have a dietitian on staff who does nutrition services and consults. We have a multitude of survivorship programs. We do community outreach. We're gearing up for a early detection day in September. Henry Ford is bringing their mobile mammogram bus into town, and we look forward to partnering with them for multiple other community outreach events going forward. And then we have some additional services. Also, we've just received 2 grants to open a food pantry here on site. And I was just notified last week that Cancer Hematology Centers are bringing a mental health provider on site as well. So good things happening every day right around the corner. The primary physicians with Cancer and Hematology Centers are Dr. Paul Adams, Dr. Kilo Katato, Dr. Binu Malhotra, Dr. Rizwan Danish, Dr. Alyssa Kipke, and Dr. Christopher Ciarto. There used to be 2 practices here, and these physicians made up those 2 practices, and they've been here with us since 2002, and just recently due to the way the market is going and whatnot. And they have combined with Cancer and Hematology Centers so that they are able to continue providing services to our community here in Flint and continue to see and take care of our patients. So the reason that they need so many doctors and providers up there, they do see over 1,500 new patient appointments annually. They provide over 15,000 treatments annually. So we have an infusion center here. Patients come in, they may get an injection. It may be like an IM injection that they receive in their arm or their leg. They may be connected to an IV infusion type of treatment, but they do a multitude of those. And then in general, they provide services for over 30,000 unique patients annually. So 30,000 people walk in and out of our doors annually. And those are for conditions like lymphoma. The top three cancers here in Genesee County, we look at lung, we look at breast, and we look at prostate, among a multitude of other cancers that come in and are treated here, here on our facility. Here's just a sneak peek. This is one of the exam rooms for CHC, and here's our infusion room for CHC. Our radiation oncology services, we have an exclusive practice agreement with the Collaborative Radiation Oncology Group, Dr. Paul Cottrell, Dr. Tushar Shah, and Dr. Anjali Sarapalli. They see all of our radiation patients and collaborate very closely with the medical oncology team. The medical oncology team is up on the second floor. We're on the main floor, and then we have a garden level for radiation. And here are just a couple of pictures of our rooms downstairs, our waiting room, and one of our treatment rooms with one of our radiation machines. We pride ourselves rather on having a multitude of patient and community services, most of which are grant or trust funded. We provide transportation for patients through almost exclusive grant funding. We provide over 5,000 medical rides per year with our MTA partner, Rides to Wellness, and over 800 individuals are served each year with those transportation services. Our dietitian sees over 850 consults per year to help people who have trouble chewing or are having a lot of nausea and having trouble stomaching foods, having trouble chewing foods. We do a lot of community outreach. We have a breast cancer screening here on site every year, and now we're reaching out to do community programs like our early detection day that I mentioned. And then we have just a ton of survivorship programs. Our survivorship programs are free to all Genesee County cancer survivors and caregivers. It doesn't matter where you got your treatment. Please come and hang out with us. We have up to 36 classes per year. We do art therapy, we do exercise therapy, we do journaling, and we have support groups. And we have an annual survivor retreat, and they do fundraising for that. They do like bake sales and crafting sales and stuff to raise money so that they can take themselves on a retreat every year. And I will mention our primary grant partners are Community Foundation, Pink Party through Security Credit Union, and the American Cancer Society. That is who we are and what we are about. I will take any questions that anybody might have. I know that was quick, but got to keep us on schedule.
No, it's so important after one of the things, one of the goals of the webinar, right, is to educate, make sure people understand, and then give people a resource. And we're so thankful for you for explaining the resources we have available in our community and highlighting the importance of those major medical centers to set precedent, set guidance that we can then implement here locally and have resources to make sure our Flint community can get access to. So shout out to you. Thank you so much. I see Anar is shouting out "Go Blue," and we'll give respect to our friends across the street. Good to have you. Thank you so much for your expertise and your willingness to share the resources with the community. Dick, I'm going to bring you up to talk a little bit about the Healthy Flint Research Coordinating Center and the research symposium that's coming up really soon. So if you could lead us out with a couple of words about the symposium.
So, hey, everybody, I'm an associate prof here in public health at MSU downtown, and I'm sharing that Flint's preeminent health research symposium is coming up in 4 weeks from today. So join us September 11th for the 9th annual symposium. We average somewhere around 120 to 150 people. We have a really good mix of community and academic partners from at least 4 or 5 of the academic institutions that are represented doing research in Flint. So invite your colleagues to this free event. I'm going to drop the link in the chat for registration. Be sure to register so we know, so we have a good count for food. We did hear your feedback, and we've spread the program out a little bit. We always try to accomplish so much in such a short time. And one thing we've done is we've removed the breakout sessions in the afternoon in favor of giving everything a little bit more elbow room, a little bit more networking time, and we will all stay together in the big room throughout the day But everything else basically will be the same. There's lots of time for networking during breakfast. We'll have a poster session, a lunch, of course, for networking. So it's really just a great time to see people in person in this Zoom world that we live in, and see what kind of research is going on, and see some of our local partners and academic partners honored with awards at various levels on both the community and academic side. So please join us in a few weeks at the HFRCC Research Symposium.
Yes, and we will be live. So join us all, because we're all going to be there for the webinar, and we're going to be bringing you wonderful information. So thank you so much, Dr. Sadler, for talking to us about the symposium, and we look forward to being there. Make sure you register, and we will see you there. Thank you so much to Dr. Weiss. Thank you so much to Kim Van Slyke. Thank you so much to all of you who asked your wonderful questions in the chat. A reminder about our continuing education units for community health workers, and we can't wait to see you next month at the research symposium. Bye.